to your group. First, some housekeeping. We have interpretation in French and English. Please go to the globe icon and select your most preferred language. And for question and answer, please use the Q&A function on the Zoom platform. You will need to tell us your name and the name of the media organization you represent.
Oui, bonjour à tous. Merci de nous avoir rejoints à ce point de presse de l'OMS. Si vous souhaitez écouter la conférence en français, merci de cliquer sur l'icône en forme de globe qui est située tout en bas de l'écran à droite. Et si vous avez des questions, merci de bien vouloir préciser votre nom et le nom du média que vous représentez. Merci.
Merci, Yasmin. And now joining us from Brazzaville, Congo, is Dr. Moeti, the WHO Regional Director for Africa, and Dr. Moeti will introduce our panelists. Welcome, Dr. Moeti.
Thank you. Thank you very much, Mary. So warm greetings to all of our colleagues in the media and to everyone watching this press conference online, where we will discuss the COVID-19 situation in Africa and the vaccine rollout in particular. I'm very pleased to be joined for this conversation by Ms. Aurelia Nguyen, the Managing Director at the Office of the COVAX facility at Gavi, the Vaccine Alliance, who will update us on COVAX's efforts and work to ensure access to COVID-19 vaccines in a very challenging and competitive global context. A warm welcome to you, Ms. Nguyen. I'm also very happy to welcome Dr. Ayoade Alakija, my dear friend and sister Ayoade, who is the chair of the African Vaccine Delivery Alliance, who will talk about Africa's need for vaccine equity and preparation for delivery. We've now passed the sad milestone of 8 million COVID-19 cases on the African continent. But for the 9th consecutive week, new cases have declined, with another sharp drop of 30% in the past week. This decline is good news, but it should not be a reason to let our guard down. Vaccination coverage remains very low, with only 50 million or 3.6% of Africa's population being fully vaccinated. 32 African countries have reported the Delta variant and 44 have the Alpha variant, for example. And we've seen several times how quickly COVID-19 can flare up when restrictions are eased. These factors come together to increase the risk of further waves of infection and loss of life in this pandemic. So even though it is at times incredibly challenging, adhering to the personal preventive measures will help to protect people from dying or falling very ill due to COVID-19. It is clear from the disappointing news of the COVAX facility's 25% downward forecast, which we'll hear more about from Ms. Nguyen, of vaccine deliveries this year, that export bans and vaccine hoarding still have a chokehold on the lifeline of vaccine supplies to Africa. As long as wealthy countries lock COVAX and the African Union out of the market, Africa will miss its vaccination goals. The 470 million doses now expected via COVAX by December this year are enough to vaccinate just 17% of all Africans, short of the 40% global target. Even if all planned shipments via COVAX and the African Union arrive, Africa still needs almost 500 million more doses to reach the year-end goal. At this rate, the continent may only reach the 40% target by the end of March next year. I took part two days ago in a meeting between the African Union Special Envoy and the team, including the Africa CDC Director, the Afrexim Bank, the UN Economic Commission for Africa, and WHO and Gavi as COVAX representatives to strategize on this challenge. This was an important conversation about how to continue to work together and secure support for vaccine supplies in Africa. I'm encouraged that when deliveries pick up, as they have after a near standstill for months, African countries show the resolve to keep the vaccine rollouts moving. Last week, 13 million doses were administered in Africa, up from a weekly average of 3 to 4 million in the previous weeks. Excuse me. As WHO, we're working side by side with governments and our partners to get the vaccines into people's arms quickly. With over 200 staff in place across Africa to support the vaccine rollout, WHO is assisting countries to secure the additional staff they need, the financing, to strengthen supply chains and logistics, and to boost demand for vaccines. Globally, there is much discussion now around booster shots, with some countries starting to provide them for their populations. These decisions are sometimes moving ahead of the science. There is not yet consensus on whether immunity against severe illness from COVID-19 wanes over time to the degree of requiring booster shots. Current evidence indicates that third doses should be given only to people facing a high risk of severe illness and dying despite being fully vaccinated, particularly those with compromised immune systems. For now, while so many people around the world are yet to receive a single dose of COVID-19 vaccine, fully vaccinated, healthy people should not be given a booster dose. I've said many times that it's in everyone's interest to make sure the most at-risk groups in every country are protected. As it stands, the huge gaps in vaccine equity is not closing anywhere near fast enough. The quickest way to end this pandemic is for countries with reserves to release their doses so that other countries can buy them. Countries that have pledged doses should urgently deliver on their promises now, not later, and scale up vaccine sharing. Manufacturers need to be more transparent about their supplying schedules, and countries with enough doses should give up their place in the manufacturing queue for COVAX and AVAT. In closing, I'd like to congratulate Guinea on having ended the Marburg outbreak yesterday. This outbreak was used as an opportunity to reinforce health and prevention messages in communities and to boost cross-border surveillance. My congratulations to the communities, the health workers, the government leaders, and partners involved. This was one of many health emergencies in addition to COVID-19 that countries are dealing with. For example, Nigeria and Niger are also responding to cholera outbreaks, Madagascar to plague and a devastating nutrition crisis, and there are ongoing humanitarian crises in northern Ethiopia, Mozambique, and the Central African Republic, among others. As WHO, we're supporting countries to save lives in times of crisis and to build stronger, more resilient systems to mitigate the impacts of these external shocks. Finally, I'd like to mention that tomorrow is World Patient Safety Day, which serves as a reminder that healthcare should be provided with compassion and respect by health workers who have the skills to succeed and in clean and safe environments to prevent the spread of infections. We've seen how important this is during the COVID-19 pandemic. This year, we're calling on everyone to act now for safe and respectful childbirth by making sure that the needs of pregnant women and mothers are heard and acted upon, and that they and their infants receive quality care. This serves as an additional reminder of the many areas of collaboration we have as WHO with ministries of health and other stakeholders in addition to COVID-19. So I look forward very much to our discussion today. A very warm welcome again to my fellow panelists, and thank you for having joined us.
Thank you very much, Dr. Moeti. And now to you, Dr. Alakija. Please tell us about the steps that the Africa Vaccine Delivery Alliance is taking to ensure vaccines are available in Africa.
Thank you very much, Mary, and thank you to my sister, Tshidi, Dr. Moeti. I'm honored to be here with you today. I'm honored and somewhat sad, as this morning I was going to start with a different statement, but this morning my household lost Elizabeth, a 30-year-old mother of 3, including a 2-month-old baby that she just had. She died. We assume of COVID because she was unable to breathe overnight. She was unvaccinated, and the health center in Abuja, Garki, refused her care and treatment until she had paid a $1,000 deposit. Before we could get that deposit to them, she had died. Why did Elizabeth die? That is why we're here today. That is the reason why we're having these conversations around vaccine equity. If she had been vaccinated, she would almost certainly be alive today. The global pandemic has really revealed the international linkages between nations and societies, and the numbers of COVID cases and deaths are serving as a daily reminder of the underlying inequities that exist, such as that I just described. And that despite or perhaps because of these international linkages, COVID has put a spotlight on the global power imbalances that are between the countries of the global south and those that are able to have vaccines and those that are able to bounce back from COVID as a result of their greater wealth or their ability in this case now to begin to provide booster doses. As the world rolls out vaccines, we're seeing this particularly in Africa, the equality being exacerbated by the vaccine haves and the have-nots, and it's leading to a world where, as Dr. Moeti so eloquently described with the numbers she spoke about and the 25% drop that I know Aurelia will also speak about, we now have a situation of the haves and the have-nots. Now, yes, is the time that we need to address the underlying causes of inequity and inequality which have been compounded by this pandemic. And we need to really begin to look beyond COVID to ensure that the Elizabeths of this world, and so many like her, do not lose their lives because of an inequitable world. But as we hold the global north accountable, Mary's question was, what is the Africa Vaccine Delivery Alliance doing to get vaccines into people's arms? And the truth of that matter is very little right now because there are very few vaccines. So as we hold the global north and their leaders accountable, we must also hold our own African leadership accountable for the failures, to my mind, of leadership at this critical juncture. Dr. Moeti spoke about transparency and we have argued, myself almost the most loudly of all, about transparency from COVAX and from all our partners. But how about transparency from Africa? How about leadership? Other than the leadership shown by Cyril Ramaphosa of South Africa, Paul Kagame in some instances in bringing a coordinated African response, there has been a very loud silence from the rest of Africa's political leadership. And even worse, some of our leaders have seen this pandemic as a way to enrich themselves and to take even more from those in need. We're hearing from the streets, we're hearing people who are hesitant about the whole issue of vaccines because why are our leaders not talking about it? Why are our leaders not calling for vaccines? Why the COVID relief, the social intervention funds that were put out for COVID to help people were in some countries hoarded or squandered by political leadership. So there's a basic lack of trust that we're also going to be dealing with as we roll out these vaccines. I want to touch upon the reason why we don't have vaccines. Dr. Moeti referred to, the Africa Vaccine Acquisition Trust, which was supposed to have delivered by now millions of vaccines across the country. To my own country, Nigeria, they should have delivered by this month 3 million vaccines. And I can tell you that Nigeria has only seen 177,000 Johnson & Johnson doses. And what is now happening is that Nigeria has decided that because that supply is so sporadic and is so uncertain at the moment, that those vaccines are going to be used in humanitarian settings and in hard to reach areas and areas with people affected by conflict and crisis, IDPs, refugees, etc. These are the real consequences of this lack of vaccine equity. So we're asking also African leadership and those who are negotiating for vaccines within Africa to be transparent. I had a meeting the other day with one of the manufacturers that is fill and finishing in Africa, who told me that 30 million doses of the Johnson & Johnson vaccine had to be destroyed a few months ago. Why were we not told this? Why was the African continent, why were African leaders not told that the vaccines they were paying for had to be destroyed and therefore were not actually in that supply chain? We need transparency. Transparency is not just for COVAX. We need to know not the vaccines are coming next week, but we need to know how many vaccines are coming and when they are coming so that we can prepare on the ground. We can prepare with the demand creation. So what are we doing? let me go to the political level, because what we've been engaged in so far has been a fight for vaccine equity. And as the UN General Assembly prepares to meet next week, and the special session led by President Biden is being convened, I urge African leaders that we call on them to ensure that in the first sentence of their speech, they mention equitable access to vaccine, that they ask the rich countries of the world, that their entire speech, to my mind, really should be, where are Africa's vaccines? Where are the vaccines for the low and middle income countries of the world? And for me, if I were coordinating their action, once they've asked for vaccines and what they've asked the world, what they want us to do with COP96, in the fact that we're being left behind, then they should walk out until the world produces the vaccines that are needed to save our lives, because our lives matter too. What are we doing? We are preparing the ground. We are, the people like the Africa Alliance and academic partners like McGill University are working with us to create demand, but not just to create demand on the ground, but also to begin to map out the various products and the various logistical hurdles that might be met along the way. But really, to all of you, without knowing the vaccines that are arriving, and I want to thank COVAX, who have met the demand at the moment, not the demand, but they have met the moment, because as we have critiqued the work they've done, they have come back and they have modified their action, and they have changed, and they have become more inclusive. But we also call for Africa to be more inclusive. A health leader's job in Africa is to secure health, not to purchase vaccines or to be going around the world looking for vaccines. Let us health leaders do our job, and let the political leaders do their jobs. And so as Joe Biden and Boris Johnson and Macron and co are at the forefront of their fight for vaccines for their people and making sure their countries are vaccinated, I call on Africa's political leaders. I call on President Buhari. I call on President Kenyatta, all of the African leaders, the giants of this continent. I call on them to stand up and to go to New York next week, not just to have a chat or a conversation about what is good about the world, but to call on the world to provide vaccines so that Elizabeth's life would not have been in vain. Thank you.
Thank you very much, Dr. Alakija, for that passionate plea for vaccine equity for Africans. And to you, Ms. Aurelia, could you tell us about the challenges countries are facing handling many different types of vaccines and some coming in small quantities? Kindly highlight the ongoing effort by Gavi, the Vaccine Alliance, and partners to secure more vaccine doses for Africa.
Thank you, Mary, and greetings to Dr. Moeti and Dr. Alakija, and I'm very sorry for your loss today. And good afternoons to colleagues in the media. Thank you very much for the opportunity to join you today. So maybe let me start by stepping back a year ago. We set up COVAX to ensure that all countries had access to safe and effective vaccines. And with the support of the international community, with the drive of countries, we have raised $10 billion to fund the procurement of vaccines for lower income economies. And we've signed legally binding deals with manufacturers for 11 vaccine candidates. So our deliveries to Africa began in February. They were very much a trickle, as has been just highlighted, but they are starting to pick up pace. And today we have delivered over 75 million vaccines worldwide. The figure today stands at 280 million to 141 countries, and 49 of those countries are in Africa. So I'm pleased to say that we have a mechanism that is working. We have new shipments arriving on the continent in Africa on pretty much a daily basis. In August, we delivered 21 million vaccines in Africa through COVAX, and that was an amount that was equal to the 4 months beforehand. So we're really starting to see a very rapid increase, and we have supplies and funding that should help us protect 37% of the population and what we call our advanced market commitment countries by the first quarter of next year. And so this leads me to the key messages I'd like to get across today. The first is that we're entering a really critical period for delivery. The coming months are going to be extremely busy. It is the largest and most complex rollout of vaccines in history. And along with the government health ministries on the ground, with our partners, WHO, UNICEF, and others, we really have to all work hard together to ensure that we put in place the conditions to have a successful rollout. And that means keeping a very close eye on the absorptive capacity so that we can be confident that all the doses we deliver are able to be used. And very much as has just been asked, there are several aspects and sources of vaccines to consider. Also here to highlight and give thanks to the World Bank and other multilateral agencies which have helped with the funding to be made available to countries to invest in technical assistance and all of the other aspects of delivery. And again, here we will be working hard to ensure these mechanisms are utilized and we have the preparations put in place. I also want to talk a little bit about some news on COVAX's ultra cold chain rollout, which will be important for managing the supplies of the mRNA vaccines that are reaching the continent. Working with our partner UNICEF, this has been the largest deployment of ultra cold chain ever undertaken, and it's been carried out in record time. We have 52 of our advanced market commitment countries that have requested support. And we've got 310 units of ultra cold chain equipment underway. This is really quite a remarkable achievement in terms of international logistics, with 87% of countries that are on track to receive their equipment by the end of September. The second perspective is that I want to share is the work that we do in partnership with the African Union, AFAT, and other regional partners in terms of fighting to secure more doses for the region. As you know, and as has just been highlighted, last week we issued an updated supply forecast. It didn't make for very happy reading. We saw, on the one hand, we have a scenario where we see 470 million doses being made available for delivery in 2021, and that will rise to 940 million doses at the end of 2022. But so those are a good amount of doses, but the timing is not good, and we want the doses sooner, and we're not happy with the pace at which some of our manufacturers are supplying us. And so as we look at September being a very busy month, a lot of international summits, and seeing what we can do in our power to really help improve the progress. And here I want to call out three key areas. So first, the need for transparency from the manufacturers on their production schedules. So very much echoing Dr. Alakija's call right now. The manufacturers have a role and responsibility in the equal distribution of doses. We are also asking countries that have pending orders to swap places in the manufacturer's queue with COVAX if they've achieved higher levels of coverage. We have contracts in place, we have funding in place. We want to be able to use those and access the doses sooner to be able to supply against our committed supply. And then lastly, we're asking countries to expand and expedite the dose donations to COVAX rather than keeping them in stockpiles while they consider options for what to do with those doses. So as the special envoy to the AU said on Tuesday when he was in Geneva, COVAX is only as strong as those who made commitments to support COVAX. And now it's really time for those that made commitments to COVAX to match their words with action. Thank you very much for your time, and I look forward to taking your questions.
Thank you very much, Ms. Aurelia, for that update. So it is now time for journalists to ask your question. You have heard from all our panelists. So to ask your question, please use the Q&A function on the Zoom platform. Tell us your name and the name of the media organization you represent. If you want to go live, please indicate on the Q&A function as well. We also have on hand our experts, Dr. Tiano Balde, who is the Deputy Incident Manager for the Africa COVID-19 response here at the WHO Regional Office. We also have Dr. Mihigo, who is the Coordinator for Immunization and Vaccine Development Program, and Dr. Humphrey Karamagi, who is the Team Lead for Data Analytics and Knowledge Management. So they are here to also answer your questions. So we are going to start with the questions. So our first question is from Naftali. The first question is coming to you, Dr. Alakija. What is the progress of vaccine acquisition under the Africa Union-led initiative? And then the second question is to you, Ms. Aurelia. Is it possible to meet the 10% vaccination target in the coming months? To you, Dr. Alakija, first.
Thank you very much for that question. I think the information I have about the Africa vaccine acquisition is what is in the public domain. That has also been shrouded in much secrecy, and there is not very much information available. What we do know is that we were told that there would be 6-point-something million vaccines delivered by September of this year. And then from there on, that there would be 4 million vaccines from J&J delivered every week. What I can confirm is that that did not happen. And so when I call for transparency, I also call for that mechanism to be more transparent about the deliveries and the vaccines they actually have in hand. We are working with manufacturers, and I have had detailed discussions with manufacturers who will actually be presenting to us later today about the challenges that they're facing. And you would all have heard about the vaccines being taken from South Africa and being exported to Europe and then back into Africa. We've been assured that this will no longer happen. However, the manufacturers are still telling us, those within Africa, that until they can have their own licensing and be in charge both of actual fill and finish, as well as the delivery and the scheduling of delivery, it is unlikely that we're going to be getting the numbers we need. So to give you some straight numbers, 30 million doses were destroyed by Aspen this year at about May, June. And there is a question as to whether that information really should have been shared with countries, because as opposed to COVAX, which we're very grateful for, that is free, the vaccines that are coming out of that vaccine acquisition from Africa are being paid for by countries. And actually these countries are taking loans to pay for vaccines. So these are tax dollars and these are loans. So there's an even greater need there for transparency. And I'm afraid right now that it is relatively opaque and we do not know exactly what's going on. Nigeria has paid for 29 million plus vaccines and has only received to date 177,000. So let us keep asking those questions. Over.
Thank you, Dr. Alakija. Ms. Aurelia, on the 10% target, please.
Thank you very much. So the WHO stated target was 10% in September, which I think is unfortunately not within reach at the moment. Where for the supply that we have contracted, we should be able to reach 10% on the continent in the coming months, and then 20% towards in terms of supply made available towards the end of the year, beginning of the year, and then eventually 30 and 35% in February, March of next year. But that is very much dependent on the supply coming through. And again, I can't emphasize enough the fact that we have been suffering from export restrictions, notably from India, unfortunately, due to the unfortunate epidemiological situation there. But we really need for that export ban to lift now. We've been suffering from the manufacturers having a lack of transparency and not prioritizing COVAX and prioritizing other bilateral deals. And so that supply needs to come through. It also depends very much on the preparations within the countries being put in place as quickly as possible, because it will be a very, very rapid ramp up to be able to deliver the number of doses needed to reach that target.
Thank you, Ms. Aurelia. Paul, please ask your question.
Yeah, thank you very much. My question goes to Dr. Moeti. The first question is on what is the latest regarding expanding access to testing, considering the testing access is still remains a major issue in many African countries. Then the second question is a comment on the recent results showing promising performance of Ebola vaccines among children in Sierra Leone. So what does this result mean for Africa's Ebola response currently and in the future? Thank you very much.
Thank you. Thank you very much. I could not make out your second question clearly. Do you mind repeating it? And
okay, so this week, we read the report of a clinical trial in Sierra Leone that tested Ebola vaccines in children, and it shows that the result is quite promising. So I want to know what vaccination efforts in children, what roles will this play in Africa's Ebola response?
So first, the question about what are we doing to support expansion of testing. We have all along throughout the pandemic worked very hard, starting with a global partnership for procurement of testing supplies, equipment, supported countries in Africa to acquire all the vaccine, all the testing supplies that we could get our hands on, frankly. We have, of course, seen a certain number of countries that have never been able to test at the level that is recommended by WHO as the supplies ebbed and waned. And at some point, this was a really significant challenge. At the moment, many African countries are still mainly using or reporting on the use of the PCR test, while others have expanded to using rapid diagnostic tests. So we are encouraging the adoption and the use of RDTs in Africa, and we are working to establish a way of using them so that testing can be available at the peripheral levels outside of the main urban areas, and encouraging as well, adding an element of tracking the presence of the virus in a proactive way with the predominantly testing of travelers and testing of symptomatic patients that has been the pattern up to now. So what I'd say is that we are advocating for countries to adopt the use of rapid tests, which are more flexible, which are more versatile, which can be used to cover countries' territories, which require simpler technologies and simpler and less skilled workers. And we are seeing that this is starting to be adopted. We have a very interesting community surveillance initiative that we are implementing in a number of countries that we'd like to expand as countries continue to navigate the situation of testing versus still being required to identify, track the virus and take public health measures. So as far as the clinical trial on the Ebola vaccine in children is concerned, that this is a vaccine that can be used with efficacy and also with safety in children is extremely good news. So it means then that when there are cases of Ebola or when there's an outbreak of Ebola, this is a vaccine that can be used more broadly, including to protect children from being infected by Ebola. So this is a very important finding that can be worked into the process of preparing supplies eventually and ensuring that such a vaccine is available as part of the tools that can be used in responding to threats of Ebola outbreaks when they occur.
Okay, thank you, Dr. Moeti. Sarah Jevin, are you ready to ask your question?
Yes, thank you so much. My question's for Dr. Alakija. What was the stated reason Aspen told you that it destroyed doses? And can you please repeat the number that they told you they destroyed? Thank you.
Thank you, Sarah. I did not mention Aspen by name, so that is an assumption. Just let's clarify that. But I'm sure that it's a direct extrapolation. That's fine. The 30 million doses were destroyed because of the issues coming out of the emergent factory in Baltimore in the US. They're not the same as the ones that were destroyed in the US. These were the ones that had actually already been completed, fill and finish in South Africa. And they were destroyed because they were part of batches 5 and 6 that had problems, and the factory, I think, is now back up and running in the US, but unfortunately that affected our backlog. But I think I want to be clear that I'm not so much speaking to emergent, but I'm talking about the issue of transparency. And at the time that those doses were being destroyed, we were being told on the African continent that vaccines were arriving next week. Countries, including my Minister of Finance in Nigeria, were being urged to sign contracts to purchase vaccines that we knew were not being produced. And that is where I think the issue of transparency is. And we need to get this clear, that we need to be honest as to, we know there's a supply problem, but we need to be honest, and there needs to be transparency and accountability with those both who are producing vaccines and those who are making the arrangements to get the vaccines to countries. If I may, I have one very quick point also on something that Aurelia just said about the ultra cold chain, which, Nigeria is a country that has also received, I think, about 60 so far of these ultra cold chain equipment. And there's a concern from the country level that I think is important that has gotten out in public fora, that these are going to end up being white elephant experiments. And perhaps we should start to look more at people-centered focus, because instead of taking an ultra cold chain machine and putting it in outer Zamfara state or outer Ekiti or Ondo state, where it's going to need generators and air conditioners, and where it's going to cost even more money and also affect the environment, perhaps we should be more creative in mass vaccination centers, which is one of the things my team and I have been working on. And when these Pfizer vaccines and the Moderna vaccines arrive in country, why don't we roll them out in these wonderful boxes that they come in the cities of Lagos and Kaduna and Kano. This is for Nigeria, in Nairobi, in Kampala and other parts of Africa, so that we're not needing to put these machines and this equipment and more air conditioners in places where they're just going to rust in another few months. I think really we need to start thinking beyond the old way of doing things and putting resources where they're going to be useful, which will also help the economies of these nations. Over. Thank you.
Thank you, Dr. Alakija. So we have a question from Christine. COVAX announced that it won't be able to reach its 40% vaccination target in Africa. How do you explain the vaccine supply challenges? What would the impact of the change of objective on the target population? How many people do you now plan to vaccinate, and over what period? I'll start with you, Ms. Aurelia, and Dr. Moeti can complement.
Thank you very much. So we do have the funding and the contracts in place to vaccinate what we estimate will be about 37% of population in Africa, but where we are falling short is on the timing. We were very much hoping to be able to deliver our stated numbers of doses in 2021. Now, with the shortfall in volumes that we're seeing from the suppliers, that is more likely to be March 2022. And so we are holding fast to our target, and we'll seek to support countries if they do want to go further than those targets as well. But unfortunately, it will take longer due to those production issues. And those production issues are largely threefold. First of all, the production base in India is part of what we were relying on, and due to export.
Do you mind answering in French, because the question was asked in French? Sorry, and Dr. Nguyen can compliment in English, yes.
Avec plaisir. Vous voulez que je reprenne dès le début ou je continue?
Yeah, go ahead, go ahead.
Oui, dès le début, pardon, c'est avec RFI, merci.
D'accord, donc bonjour aux collègues de RFI, bonjour aux collègues francophones. L'objectif qu'on a actuellement en termes de doses, on a un financement et des contrats en place pour 37% de la population, donc on va se tenir à notre objectif. Mais malheureusement, le timing n'est pas celui qu'on voudrait. Nous aurions voulu pouvoir atteindre cet objectif d'ici la fin de l'année, mais ça, dans nos prévisions actuelles, ça ne sera pas avant mars 2022. On a eu plusieurs problèmes de fiabilité des livraisons qui nous ont été données par les producteurs. Donc tout d'abord, ce sont les doses sur lesquelles nous comptions qui sont produites en Inde, et à cause de la restriction des exports, nous n'avons pas pu avoir accès à ces doses-là, et c'est pourquoi il est vraiment important de faire un plaidoyer auprès du gouvernement indien pour pouvoir avoir accès aux doses qui sont produites en Inde. Deuxièmement, nous avons eu plusieurs producteurs qui ont pris du retard et qui ont eu des problèmes de production, notamment Johnson & Johnson et AstraZeneca, donc leurs livraisons sont retardées. Et troisièmement, nous comptons sur un certain nombre de vaccins qui sont encore en train de suivre les processus d'approbation réglementaire, donc par exemple Novavax et Clover, et donc le temps que ces processus se mettent en place, pour l'instant, nous ne pouvons pas avoir assez doses-là. Donc, nous maintenons notre objectif. Malheureusement, nous avons pris un peu de retard, et il est important justement d'accélérer les livraisons à travers les dons de doses et à travers plus de transparence auprès des producteurs pour savoir quels sont leurs délais de livraison, pour que nous puissions planifier et travailler avec les pays pour faire les préparations nécessaires. Merci.
Dr. Moeti, do you want to weigh in?
I don't have much to add. I think just, I think Ms. Nguyen has said it very well. The timelines have changed clearly because of the delays that have been very well articulated. So we were not expecting to reach neither the 10% by the end of this month, nor the 40% by the end of this year. So it's shifting the time into next year. We do have the intention of getting to 70% of coverage of the population. This was initially thought to be where we would be by around the middle of next year. It might also shift later. However, I think if we come back to what we are requesting, is to redress some of the challenges that are being articulated here, and to see if through other means, through the release of supplies that have been reserved by some countries that are not immediately going to use them for COVAX and for the African Union's platform, we could catch up on some of these targets, perhaps by the end of the year. So I think there's a direct link between these projections now in the face of the challenges and the requests for different actions by those that control the manufacturing and those that have got in reserve some doses of vaccine that they're not going to use for their population, to take action urgently to release them in one way or the other for African countries to have access.
Thank you, Dr. Moeti. Ashvin from Observer Times, are you there? Please go ahead and ask your question.
Yeah, thank you for considering my question. We have observed that the governments of individual countries in Africa not implemented and used Doha Declaration Article 31st on trade-related aspect of intellectual properties. Can Doha Declaration enhance compulsory license to boost production of COVID-19 vaccine and overcome vaccine inequity in present situation? Thank you.
Thank you, Ashwin, for your question. Dr. Richard, do you want to start? And Dr. Moeti can complement.
No, thank you, Mary. So I think the efforts on vaccine production on the local, on the African continent, it's not necessarily linked to the intellectual property rights. I think there is a lot of efforts that has been done so far for technology transfer, for releasing the necessary support to the country. So I think the bottlenecks doesn't really lie per se, and this has been a general consensus that intellectual property alone will not, lifting that will not solve the solution. So I think the current thinking for the initiative that is being championed by the African Union and for which WHO is really providing a lot of support in fostering a healthier vaccine manufacturing market in Africa, looks at a different aspects of the value chain of the vaccine production, including indeed the intellectual property right. But I think it's a long process that has started, and I think it's an irreversible process, definitely, where we're going to see not only local investment on the Africa, having healthier markets here, and then, of course, indeed, at the end of the day, lifting some of these bottlenecks around intellectual property to ensure that on a long-term perspective, vaccine can be safely produced on the African continent. Thank you.
Thank you, Dr. Richard. Dr. Moeti?
Yes, thank you. Just briefly to say that, I mean, in addition to what Richard has said, of course, we are in a global crisis, which is causing such devastating not only health impact in terms of the people who are ill and the people who have died of COVID-19, but which has really caused enormous economic damage in many countries, which in Africa is projected to cause damage that will go on for years into the future and affect all aspects of life. So I think in the context of such a crisis, this could be an opportunity to explore very actively within a time frame that is relevant for such a crisis, what could be done in terms of technology transfer, even waiving intellectual property, to be part of the solution to some of the gaps that we've been talking about in terms of speed in acquisition of vaccines. My colleague Richard is quite right. This is not something that can be done quickly. So we need a series of processes, the release of doses for purchase, the donations quickly, the technology transfer in terms of some of the work that's going on very urgently now for local manufacturing, waiving intellectual property where that could be helpful as part of that process. And I know these discussions are going on within the framework of the World Trade Organization. I think in the context of such a global crisis, there really could be space to exceptionally take some decisions and then review them. You know, we had this experience during the acute phases of the global HIV pandemic, which has become essentially now an African problem. And there were some very difficult discussions that took place and actually not much progress. So, and we have seen the impact in terms of the millions of people who died of HIV. So I believe a crisis like this merits discussion of this in a very active way so that we have all the possible solutions coming to bear to reduce these inequities that we've discussed.
Thank you, Dr. Moeti. So the next question is coming from Camille Lafrance from Juan Afrique magazine based in Paris. The question will go to you, Ms. Aurelia, and Dr. Alakija could weigh in as well. There is a high discrepancy between the number of doses donated by rich countries, either through bilateral agreement or through COVAX, and the number of doses delivered in a number of African countries. So the question is, how can it be explained? Is there a risk that doses not delivered yet will reach their validity date? And how many doses through COVAX have so far been destroyed? So Ms. Aurelia, you go first, and then Dr. Alakija can weigh in.
Do you want me to answer in French or in
And go in English, please. Thank you.
Okay, thanks. So thank you for the question. The dose donations have very, very much increased over the last month or so, which is very welcome news. But I think to your question around the discrepancy, there's probably two factors. One is that they have been committed, but the timing of when those doses are coming through is somewhat not clear. And so I guess my first point would be that for the donated doses, it's very important for them to come through as quickly as possible. The 600 million that have been pledged over 2021 and 2022. If we can bring as much of those forward as possible from a timing perspective, that would really make a difference in terms of deliveries to African countries. And then the second question, the second part is, in some instances, there has been some level of earmarking of the doses in terms of where the donations are oriented to a particular geographic region and the like. And here, I think as much as possible as donated doses can be unearmarked so that they can really be deployed to where the need is greatest, to where the coverage is lowest, and really help increase the support in African countries, that would be very, very welcome. To your second question, in terms of is there a risk in terms of validity date, so whether they would have short shelf life, I think there's two aspects here. I think one is we have been working very closely with the donors of donated doses, with the manufacturers, to make sure that there is as much shelf life as possible on the doses. But sometimes it has been somewhat limited, and so we have to work very, very flexibly in terms of using them. So again, as much visibility and planning as we can get for doses would be helpful. And then secondly, we are also increasing our knowledge of the stability of the vaccines. And so because the development of vaccines has been very rapid, hopefully over time we will have data which means that we can extend the validity date of the vaccines. And to your last question, I mean, so far it's been a very small amount of doses that have needed to be destroyed relative to the totality of what COVAX has shipped. And this is really thanks to the fact that there's been very careful allocations, very active work with the governments and all of the actors involved in deploying the vaccines to make sure that if they can't be used somewhere, they're redeployed elsewhere if that's needed. So it's taken, I think, a lot of agility, but I think relatively, I think successfully done to make sure that we really are optimizing all of the doses that we are getting. Thank you.
Thank you very much, Ms. Aurelia. Dr. Alakija, do you want to weigh in on this?
Thank you. I think Aurelia has covered quite a bit of it, but she put some numbers on it. 554 million doses have been promised. 16 million have been delivered, 16%, sorry, have been delivered so far. And we're seeing that the US is keeping to their commitments way more than other countries. 26.59%, I think they've delivered 77.1 million doses so far. Canada, 3.1%, in the UK, about 5 million doses, which is about less than 5% of what they've promised. The issue around the short shelf life of doses is a really important one, because as we're seeing different products coming in, Nigeria, let me use my own country again as an example. Nigeria currently has Moderna, has AstraZeneca, has Johnson & Johnson, albeit in very small numbers, but this causes confusion and logistical challenges further down the line, because we're not just dealing with these at capital level, we're dealing with it at sort of decentralized state and local government level. So we need to have visibility way in advance and time to plan for these doses to get to where they're needed so that they are not being wasted on our shores, because the probability is if countries are waiting to see whether they want to give a third dose or want to give a fourth dose, and then when they finally decide, oh, oops, okay, we don't want to do that, they then share those doses. When it's 6 weeks, I know COVAX says 2 months, but the reality, Aurelia, is that by the time the Canadian doses arrived in Nigeria, they had almost maybe 6 or 7 weeks on them, as with the UK doses. So we have to ask countries if they get, when they're sharing doses, to share them with a longer shelf life. But this goes right back to my issue about the political leadership, you know, back in Africa itself. And these are some of the things we call for our leaders to stand up and say, and not just President Ramaphosa, who has done a great job, I must say, or Paul Kagame. We have to tell the leaders who are going to leaders. We elect leaders for moments of crisis. And so foreign ministers accompanying them, that every side meeting they have needs to begin with, our people are dying or getting long COVID, our economy has been affected, 13.8 billion loss in GDP for every month delay in vaccination. Those are World Bank figures. So therefore, the first line of every talking point needs to be, Mr. President of whichever country, Mr. Foreign Minister, where are the vaccines? This is no longer about purchasing vaccines. This is the trip at where, and also why the trips. This needs to be the first line. This next week is the opportunity that we as Africa have to make sure the world hears our voices. It is not up to health leaders. It's not up to Dr. Moeti or myself or others like us. We elect leaders for this purpose. They need to do their job, and they cannot outsource this responsibility to middlemen and other negotiators. Thank you for the question.
Thank you very much, Dr. Alakija, on that question. So the next question is coming from Imo Edes from West Africa Democracy Radio. So I'm coming back to you again, Dr. Alakija. You answered the first question, and then I'll give the next question to one of our experts. Are there extra efforts by African government to ensure vaccine acquisition outside the COVAX arrangement? So this is your question, Dr. Alakija. And then to you, Dr. Balde, how much have other health issues like malaria, cholera, and other emergency outbreaks suffering as a result of attention on COVID? So I start with you, Dr. Alakija, and then Dr. Balde.
Thank you for that question. It's an excellent question because it again goes back to the point I've made earlier about transparency and accountability. Some countries, there's two things, you know, so there's the COVAX side and there's the Africa sort of pooled purchase side. And I think that unfortunately countries largely were lulled into a false sense of complacency because they thought that their needs were being covered either by COVAX or by the pooled scheme with Africa, which is where this issue of more greater transparency and, you know, no, our vaccines J&J are not coming, or with COVAX, no, we have supply chain issues, which they have been doing much better with, come into play. So unfortunately, most countries did not unilaterally or bilaterally go and try to purchase their own vaccines. I know Ghana did with some, you know, mixed success with the Sputnik vaccine. They went through the UAE, but most countries relied on this wider mechanisms, and it goes back again to political will. You know, I mean, I think our leaders woken up earlier to the fact that had President Buhari or President Kenyatta or with President Tshisekedi knocked on the door of Pfizer and knocked on the door of Moderna, they could not be turned down, particularly those three countries, because those are such big countries. And we cannot be the giant of Africa, Nigeria, for nothing. Our geopolitical power should have helped us in this moment. So it's a great question, unfortunately not. And I hope that as time goes forward, as we're urging them to come to the table, they will also begin to encourage their sort of ministers and leadership to get more engaged in this and to begin to ask more questions instead of sitting back and waiting to be served, as it were. Over. Thank you.
Thank you, Dr. Alakija. Dr. Baude?
Yeah, thank you, Mary, and good afternoon, colleagues. Definitely, I mean, while we are responding to the COVID-19 pandemic in the region here, since the beginning of the year, there have been almost 128 additional public health events, I mean, which has been monitored in our African region. And out of those almost 50 once we have helped, countries in responding to 50 really public health emergencies. So just to mention, yes, for sure, the magnitude of the pandemic, of the COVID-19 pandemic is having an influence on the management of the other public health emergencies, which are still, happening, which are still, being responded by member states, obviously with the support of the World Health Organization. As Dr. Moeti just said, we are about to close today the last, the last outbreak of Marburg in Guinea. It had been the same thing also for the Rift Valley fever, in Mauritania. So definitely it's creating attention to our health system because it's usually the same resources, which are engaged at the country level, for responding to all of these different emergencies. So definitely it's a major issue. So therefore it's really important that we try to get really a kind of, effective solutions, to this pandemic and to allow us also, to address the other ongoing health emergencies in our region. Thank you and over.
Thank you very much, Dr. Baude. I have a question for you, Dr. Richard. This question is coming from Anna with New Zimbabwe. How far are we in terms of reaching herd immunity as Africa? Any country so far has reached herd immunity?
Well, no, thank you. This is a very good question. The issue of herd immunity for COVID-19 disease has been very complicated for many reasons. I think as we have seen, the disease has evolved. We have seen the occurrence of several variants of interest, variant of concern. The latest be the Delta variants, which has really changed the dynamic in terms of even the way the vaccine are performing in terms of escaping the immune response against those type of variants. So it's very difficult for the moment to estimate at which level we are going to reach a herd immunity. I think what is more important for now is to make sure that we are covering as many people as possible, particularly in the high-risk group, so that we can minimize severe disease and hospitalization. I think this is really the priority number one. The priority number two, indeed, is to reach a higher coverage. And you have heard from Dr. Moet that the objective now is to go up to 70% of the population, hopefully before the end of 2022. And we hope that at that time, we will reach a level by which, if we are not being challenged by different other vaccine of concern, we might start to reach some level of immunity that collectively may interfere with the transmission and bring this pandemic to control. Over.
Thank you very much, Dr. Richard. So we are coming to the end of our briefing for today. We will give our panelists 1 minute to give us their final thoughts. But Ms. Aurelia, as you give your final thoughts, there is a question from Anna from South Sudan. We would like you to answer this question in addition to your final thoughts. So she's asking, how can you help countries that have less weaker health system? How can you help them with storing of vaccines? Then you can round up. After you, Dr. Alakija and Dr. Moeti.
Thank you very much. Thank you all for the very thoughtful questions, and it was a real pleasure to be with you today. And From the COVAX perspective, our goal is to work together with the partners in Africa to make sure that we're addressing the very severe inequity in access to vaccines that's facing the region. And so actually, I'll probably answer your question in my last remarks as well, because we have to think about how we leverage the financial support that's available, the dose donations, in terms of ensuring that the health systems are also ready to receive the vaccines and are also strengthened with a view for the post-pandemic. COVAX has financial support available in terms of strengthening of the cold chain, as well as technical assistance overall. So countries are welcome to access that funding, as well as working with the partners in the region and the multilateral development banks on accessing that technical support and that financing. We also need to accelerate and increase the dose donations. We need to push the manufacturers for more transparency around their order books. We need to make sure that those governments who have their coverage already in a healthy place, to make sure that they help prioritize COVAX rather than buy most doses. And so I think together across the partners, we can work on the ground and really make sure that we have a successful delivery. Thank you.
Thank you, Ms. Aurelia. Dr. Alakija, your final thoughts?
Thank you, Mary. In also giving my final thoughts, I'm going to answer a question that is in the chat, which is something that I often get asked by media, BBC, Sky News, or whoever on any day, about the fact that there are those who would say that vaccine supply is not the issue and that vaccine hesitant Africans are the issue. Let me be clear that there is no such thing as vaccine equity without, or vaccine confidence without vaccine equity. No equity, no confidence. The reason that the UK and the US and other parts of the world are now beginning to see 80% of certain populations, 90% in some places vaccinated, is because there's been equity, there has been choice, there has been a wide range of products available, and not only have they been available, they've been easily accessible. In some places, you don't need to go more than 5 minutes before you get, in some countries, before you get your vaccines. So it is particularly egregious for the CEO of Pfizer to say that there is, that vaccine supply is not the issue in Africa, because it absolutely is. As with the way we see people dying right now with this wave, I know it's moving across the continent, and right now in places like Nigeria, West Africa, we are seeing a huge upsurge in that wave. Right now is not the time to be talking about vaccine supply versus hesitancy. Right now is the time to be getting all the vaccines out as quickly as possible. And delivery is the key. We need to work really, really hard together with our partners. And we're in discussions with this, with Dr. Moeti and Dr. Richard and the team and UNICEF and others and Gavi about this, about how do we prepare our populations to receive these vaccines once they start to come in numbers? How do we do it in such a way that it doesn't place further burdens on health systems? There are those who are talking about doing it at primary healthcare level. But perhaps there's an argument for an all-family approach, because routine immunizations in some countries we're seeing are beginning to suffer because of COVID, because of the lockdowns. We're seeing, and I can't end this without talking about the role of women and the gender aspect of this. The women are also being left behind. Africa is being left behind. African women are being left behind in terms of getting vaccines. I spoke about Elizabeth earlier. Her husband was vaccinated and she was not. This young lady who died in my household just a couple of hours ago, because she was at home looking after the children, because she was going to market, etc., etc. So we have to look at the various aspects, and we have to work really hard towards this delivery. We cannot allow Africa with COVID to become what Dr. Moeti just said, which is, HIV/AIDS has now become, sadly, the African disease. COVID cannot become the African disease, and we cannot lose our young, we can't lose anybody else to this needlessly. So, I mean, for me, I think we need to work on this sharing of doses, that the high-level political pressure is critical within the next few weeks before the world forgets about us. And I would like to say to those friends of ours out there in the media that If the world, the G7 nations, the rich nations had brought the same energy to vaccine equity that they brought to bringing people out of Afghanistan, if they had had the same fear for COVID that they seem to have had for the Taliban in Afghanistan, they would have used all of those planes and all of those, the logistics and the incredible machinery that they put together to take hundreds of thousands of people out of harm's way so that they're not affected by a particular ideology that they don't like. If they'd use that same energy, Africa would not be where it is right now. So we call on them to use that same energy. We call on them to use the evacuation, the military might, whatever is needed to get the vaccines onto the continent and to help us deliver them from ports into people's arms. Thank you very much for having me. Thank you, Dr. Moeti. Over to you.
Thank you, Dr. Alakija. Dr. Moeti, your final statement, please.
Yes, thank you. First, Ayoade, my sincere condolences on the loss of this person who was part of your household. I think it just illustrates exactly what we're talking about. So I'm very sad, and condolences to you and the family. I think to conclude, just building on the last remarks, we are about to have, as it was said, heads of state meeting, either virtually, many, I believe, in person in New York at the UN General Assembly next week. I certainly hope, and I'm certain this will be an opportunity to have a different dynamic emerge after these days of discussion of leaders, looking at the situation of inequity across the world in low-income countries. And we remember, it's not just in Africa. Africa certainly has the lowest coverage of vaccination of any WHO region, we might say, but there are other low-income countries that are also having serious challenges. So we hope that drive, the political drive, will have decisions emerge that will change some of what is happening, some of the issues that we've discussed. In the meantime, we are working very hard to prepare our countries, working with partners, including within COVAX and now with the African Union, to really gear up and prepare for this extraordinary work that they will need to do as the vaccine availability improves towards the end of the year, we're certain, and early next year. There are many aspects that need more working. We are helping our countries with the planning, with refining their plans, ensuring that they're planning at the detail level at different localities, mobilizing not only the funding is important, but it means finding the people in time who are going to do the work, thinking about the sites where you want to do these deliveries. We are learning from the previous rounds and analyzing, finding good examples to share among our countries. And then finally, just to say again, while we are on this journey, it behooves all of us as individuals to continue to observe those prevention measures that will minimize the impact and the negative impact in Africa of the delay that we've had in acquiring vaccines. So it's an individual responsibility. And we are asking governments as well to look at those people that can't actually buy a mask, that need that extra support so that people are confident about their role in preventing transmission while they're waiting their turn when the vaccines arrive to go and get vaccinated. Thank you to all our colleagues from the media. Thank you so much to my fellow panelists, Ayoade and Aurelia, and let's continue our partnership and work for Africa.
Thank you very much, Dr. Moeti. We have come to the end of the media briefing today. A very big thank you once again to join Dr. Moeti, to all our panelists and experts, and thanks to the media for the excellent work you are also doing in making sure that the population out there gets the right information. So thank you and see you next week. Have a nice day.
Thank you. Thank you very much, Dr. Moeti. Thank you, Mary. Good to see you. Nice to meet you, Aurelia.
Likewise.
Thank you, Richard.
Yeah. Thanks, Aurelia. Bye, everyone.
Thank you.
Bye.
Bye.